discussion on refractive surgery. And as I said earlier on, when you're out and about and people say, what do you think of laser eye surgery? You can't answer them. So this is just going to be a talk through refractive surgery, really, mainly going through LASIK and PRK, a little bit about ICLs. And if we've got time, we can talk about multifocal lenses, because when your uncles and aunts and grandparents are going to a cataract surgery, they say, should I have a multifocal lens? And again, like the trainees here in the UK who don't get taught about these things, they say, I don't know at all. So a tiny bit, we know that the excimer laser is a laser that reshapes the cornea. It stands for excited dimers, as you know. We have the Visex or the Schwind. We call these platforms. There are many different platforms, and all the big companies make their laser platforms, but we have Visex or the Schwind at Moorfields. The Hertz is a number of times these little laser pulses bang, 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 bang away at the cornea. 20 Hertz means 20 times per second. But the Schwind on newer models of excimer lasers can be 1000 or 1050 Hertz, which means they're doing it at a 1000 repetitions per second. So it really is fantastically rapid. Somewhere in there is also a tracking device, because it has to track the eye movements of the patients. And the tracking device needs to be faster than the laser in order to be ahead of it with movements. The excimer laser is in the ultraviolet range, so it's outside the visible range. The ultraviolet range is, as you know, the high frequency, more powerful X-ray kind of areas with UV ultraviolet light. And it's absorbed by biological compounds, so it disrupts the molecular bonds, disintegrates them, and aerosols them. We use a femtosecond laser to create the flaps in the cornea, and we've got two, the intralaser and the Visumax. And here they are. They just look like bits of white furniture, like fridges or freezers or anything like that, but that's what we have. But they're miraculous instruments. The femtosecond laser, I'll talk about a bit more later on. So if you were a patient and you were coming into the clinic, the way that you'll be seen is that, first of all, there's a technician, opticians, and eye surgeons, or me. So the technicians will do the scans. Most patients will get an auto-refraction, they'll have an eye care pressure reading, they'll have a pentacam scan, they may have an anterior segment OCT or may not. They'll have wavefront scans with their contact lenses out beforehand. And if they come along and they haven't left their contact lenses out, it doesn't matter, because they're really finding out whether they're suitable, whether their corneas are right for laser refractive surgery. And if they are suitable, then we simply ask them to leave their contact lenses out prior to the day of surgery. For daily disposables, we might be asking them to leave them out for 3 days. For weeklies or monthlies, ask them for a week, maybe to leave their contact lenses out for a week. And for hard contact lenses, they leave them out for a month. And the rationale, as you all know, and when patients want to know why they have to leave their contact lenses out, and I say that all contact lenses flatten the cornea a little bit. And when the contact lenses are removed, the cornea can regain its normal shape, and that's what we want for the laser eye surgery. So if they've already left their contact lenses out prior to the clinic appointment, then I say to them that they can keep their contact lenses in right until the day before, but not the day of surgery. Sometimes when you do repeat the corneal scans, you find that the cornea is flatter after the contact lenses have been removed. So my little phrase that I patter out to patients of all contact lenses flatten the cornea isn't strictly true. It just distorts and changes the shape of the cornea. So that's why we ask them to keep them out. With modern day contact lenses, which are so fine, I'm sure this advice that I give them is probably old fashioned. And it's about time we did a new study looking at daily disposables or weeklies to see if leaving the contact lenses out for 3 days really does make a difference or not. They get an IOL master, if that's for the white to white for the ICL, and also if they're going to have cataract surgery, if they're older patients, if they're in their 50s, 60s. They get an endothelial cell count if they can have ICLs, OCT scans maybe, and then they see the optometrist who gets history and refraction. The pentacam scan is the most important thing that we love to get, because especially with the Bellin-Ambrosio scan, the enhanced ectasia, it shows if they have any form thrust keratoconus. It tells us what the thinnest location of the thinnest thickness, pachymetry of the cornea is. The normal cornea is kind of 500 to 580, and that's what we want to see to get to do LASIK with a flap. I'm a bit more cautious than most people in that I don't like to do LASIK with flap. In people under 25, I try to encourage them to have a surface treatment, not just because the cornea is more elastic, but also because they're younger and they've got more years to go get an injury to their LASIK flap. But having said that, injuries are very few and far between. I don't know how many of you will have seen injuries and eye casualties to corneal flaps. So the main thing we want to exclude is ectasia. That's the worst thing that you can do with somebody with an excimer laser. So the patients who are coming up to the clinic, the older ones, like I mentioned, 50s, 60s, 70s, they're going to have lens replacement surgery. The younger ones are looking for LASIK. The lower myopes, under 6 diopters, will be LASIK. As they get to be higher myopes and the excimer laser eats away more of the cornea, it's about 17, 18, 19 microns per diopter. So if it eats away too much of the cornea, I tend to go for PRK. Ectasia is very rare. Most people will do LASIK where I do PRK, so I'm overly cautious. And when it gets to higher myopes, above the -8, I tend to move them towards ICL surgery. And at -8, most of their anterior segments are deep enough to be able to house an intraocular Collamer lens. If there's anything that I say that you want to ask a question about, Osvaldo, please do keep a lookout for hands raised or text that I can't see when sharing my screen so that I can ask questions. Because questions, if you're thinking of a question, then chances are everyone else is thinking of that question.
Alex, I have a question. When you do, for example, a higher myope around 6 or 7 diopter for PK, how long do you use the mitomycin C for them?
I use mitomycin C for 45 seconds in all of them. I think that's more than most of my colleagues do. I know that some people won't use mitomycin under 3 diopters. I will use it for all cases, and for all those cases, I'll use it for 45 seconds. It doesn't seem to harm the endothelial cells. It doesn't seem to do any other long-term damage. And I haven't seen that many hazy corneas after PRK, so it is a rarity nowadays with a bit of mitomycin C. It might be that I'm overdoing it, and just a mere whiff, a tiny smell of mitomycin C is enough to paralyze those keratocytes that are wandering through the cornea, wanting to lay down scarring tissue. But I use 45 seconds for everybody.
Great, thank you.
And then between 6 and 8 diopters, it really depends on the corneal thickness, whether they're going to go for PRK or LASIK, or even head towards an ICL. And the ICL studies, as such a well-studied lens around the world, as I'm sure you know, and the quality of vision is very good, that even if people's corneas are suspect or show any hints of form frost, then to have a ICL, even for -4, -5, -6, is a good outcome. And I ask patients as well to Google ICL versus LASIK when it comes down to quality of vision. The low hyperopes, I don't like doing hyperopes because they're just a bit unpredictable. Not only because of the shape that the excimer laser carves into the cornea, but also you've got the latent hyperopia, so they are tricky. They tend to be the older ones in their 40s and that are coming through, that are early presbyopes, wanting that. And then sometimes the +1s and +2s do really well, especially with a tiny little bit of monovision. But even then, they can be a bit more tricky and their expectations can be too high. Next slide. So once again, corneal ectasia is a thing that you're most dreading inflicting on anybody. And there are 3 warning signs which are very loud in my clinic here. Can you hear me okay, Osvaldo? I'm getting a lot of chatter in the back there. They get very excited in clinics.
Yeah,
you can hear me okay, despite the noise in the background.
But we can hear you well.
Good. So with corneal ectasia, the 3 main alerts are people who are young people, i.e. in their 20s, especially below 25, thin corneas below 500 microns, and high treatments above 6. If they've got those, then they are at risk of ectasia. And it's not often, it is often rather, you get people who are young in their 20s, who have more than -6, have perfectly normal corneas, and then they've got 2 out of 3. So with those, I'd certainly do a PRK. So again, and there are I think there are quite a few LASIK surgeons who are a bit loath to do LASIK under the age of 25. When you speak to the people who work in the laser clinics on the high street and who are run by venture capitalists, they will do LASIK for everybody. Doesn't matter whether you're young, whether you're a boxer, whether you are going into the military, they do LASIK for everybody. But I'm a bit more probably overly cautious. Once again, we've seen the importance of the pentagram. We know what the normal cornea is. And the residual stromal bed is how much you're prepared to leave untouched at the end. Even though you put the flap back down again, as I'm sure you all know, that flap doesn't integrate to contribute to the tensile strength of the cornea anymore, so you have to exclude it from your calculations. In the old days, the bad old days, we used to leave about 250 microns of residual stromal bed, but that was too thin and that caused ectasia. Nowadays, most people will go to a 300 residual stromal bed. In younger people, I prefer to leave 350 microns with more elastic corneas. Maybe with older people, you could do more than 300, but talking to colleagues, they very rarely see ectasia if you're abiding by these rules. Just to remind you, the silliest things in the world are always worth reminding. There are 1,000 microns in a millimeter, 500 microns in half a millimeter. This diagram over here, I don't know if you see my cursor, is meant to be the cornea. You can see the corneal epithelium up there with all its epithelial cells. And this is some of the stroma here. It's 550 microns. And you can see the LASIK flap, about 110 microns. Occasionally, you might drop it down to 105 or 100 micron flap. It tends to be 110 micron flap because 50 to 60 microns might be epithelium. Then you've got the ablation depth of the treatment. It's not a square like that, obviously. It's a different shape. And then you've got the residual stromal bed. But just to remind those people who may not be aware of what a residual stromal bed is, the untouched cornea after all the laser. So patients on antegrade laser can have lower myopia, thicker corneas, and be late 20s or older. I'm only reiterating this because repetition is what makes people remember things. And next time you're in the bar and you're chatting to a boy or a girl or someone and you wonder whether to have laser or PRK, you can know that if they are better to have lower myopia because 18, 19 microns per diopter is going to take away less of their cornea at the bottom of the flap. So on the day, this might be very boring for you. So Osvaldo, just interrupt me at any point, but this is what happens to people when they come along for instance, for LASIK. I'm talking about what happens on the day when they come for PRK. This is what I tell the patients. If they're going to have LASIK, they'll spend just about under 2 hours in the hospital, 20 minutes in the laser room. When they arrive, they bring a terrifying consent with them, which is, I think, designed to put them off doing it because they sign all these paragraphs of the most horrific complications that I've never seen happen during 22 years of doing LASIK. But never mind, they have to initial all these and sign it. Obviously, that doesn't remove any rights from them. And they walk down the corridor here and they chat with the nursing staff about the drops they have for the month afterwards, which are steroids, teardrops, antibiotics. And then when they come for laser, they lie down on the bed between the two lasers, and the bed pivots between either the femtosecond laser, which creates the flap in the cornea, as you know, or the excimer laser that reshapes the corneal stroma. And once lying down, we do the WHO checklist of the patient and the treatment details. We put numbing drops in their eyes, proximetocaine, and then there's a rubber ring that presses on the eye with the femtosecond laser to create the flap in the cornea. 110 microns, I mentioned occasionally thinner. It takes 15 seconds to create the flap. We now have a new laser as well, the Visimax from Zeiss, which is a curved interface and therefore much more comfortable for the patient because this flat interface of the intralase puts a lot of pressure on the cornea and inside the eye, raises the pressure inside the eye up to 140, 50 millimeters of mercury plus, so really very high pressures, and that squashes all the vasculature of the artery of the retinas, and therefore the vision goes very dark for them, which can be frightening if you don't warn them. The femtosecond laser, it's called a femtosecond because a femtosecond is 1/4 of a second, and so the burst of laser is so short it's measured in a few femtoseconds. And the femtoseconds, you know, create a little bubble, tiny, minute little bubble dot in the cornea, and by creating another dot, another dot, another dot, they can gradually create all these dots, and then they can go zigzagging up the cornea to create the plane. Let me know if none of that makes sense. So they get these subconjunctival hemorrhages from the pressure of that cone, which presses the eye, bruises the blood vessels. It's just like a bruise. They can take 1, 2, 3 weeks to gradually settle down. I've mentioned before already that the pressure from the intralase is up to 140 millimeters of mercury, reduces flow in the retinal arteries, vision goes dark, but it's only for a few seconds. So it doesn't do any long-term damage. I've never known anybody have a permanent occlusion from just having the LASIK. For post-cataract patients who might be having laser for surprise outcomes or a bit of refinement owing to astigmatism, for some reasons it doesn't open the wound, and raised pressure doesn't cause the small phaco cataract wound to burst open, and they're fine. These horrible looking piles of sand are just what I described to the patients. If you're myopic, it's like taking a steep domed pile of sand on the beach and flattening it out a little bit. And that's how the laser works, by removing tissue. When it comes down to treating hyperopic treatments, it creates a steeper dome by creating an American style donut in the cornea to have a central steep hill. And these are just the two kind of profiles. So the myopic treatment thins the central cornea, the hyperopic treatment thins the peripheral cornea to leave a central steep hill in the middle of the cornea. And that's what the cornea tries to heal, as well as all the latent hyperopia, which is why hyperopes don't do so well. Once the flap has been created, The bed that the patient is lying on goes back between the two lasers. They have more numbing drops. They have some povidone iodine drops. And then we put sterile tape over the upper lashes to get them out of the way. I'm only telling you this because if you haven't seen it, it's just reassuring to know what happens. So you know what your friends are going to go through if they have it done. The lid speculum keeps the eyes open. Patients are always worried that they're going to blink or that they're going to not like the speculum. So you say to them, owing to the numbing drops, the desire to blink has gone. The cameras within the laser then recognize you owing to your iris pattern, your iris scans. They rotate the treatment according to the head position. And that's particularly good if you're treating high astigmatism because you want the axis of the treatment of the astigmatism to be bang on. And that's what the iris registration or recognition does. And then the laser fires off the repeated bursts of laser. With the tracker recognizes 10 to 20 points within each of these little green squares to realign the iris so that it can track any eye movements you have. And if you do a big eye movement, run away. If you get, there's nothing claustrophobic holding the patient down at all. There's no drapes or anything like that either. And if the patient gets up to run down the stairs away from the laser because they're frightened, the laser will chase them down the stairs because it's tracking them. No, it won't. That's obviously a joke. It'll track them as long as it can, which is not very much, and then it'll stop and carry on with the treatment once they're lying back in position again. So the patient cannot make the treatment go wrong. After laser treatment, people do different things. I put a bandaged contact lens on the eye for about 20 minutes, half an hour, just to protect, like a shield, protect them from the blinking. The eye can be very dry for the first few hours after laser eye surgery, so I ask them to put in teardrops every 5 minutes for the first few hours to keep it really well lubricated so they don't come back with a dislocated or flap or with folds or striae in the flap. But after 20 minutes, I take the contact lens out and they go home, but they carry on with this teardrops every 5 minutes. I don't think many people do that. It's initially blurred, I say to them. Immediately after the treatment, it's as if you've got foggy glasses on. So you can see, but it's as if you've got foggy glasses on, and by the evening, you should be watching television. And occasionally, if they haven't put all their teardrops in and they've blinked away on a very dry flap, you can get these dry little wrinkles on it. And if they come back with blurred vision and they do have those little striae, those little wrinkles, I tell them these wrinkles, these corrugations in the flap are like jelly that will turn to concrete over the next week or so. So we take them back in again. They need to be flattened out and ironed out. And I do that by irrigating under the flap with water for injection, not with saline, which is 0.9% saline, which is physiological saline, but with water. So that means that the cells of the epithelium and also the stroma absorb the water, and almost like a dry sponge absorbing water or blowing up a deflated lilo before you jump in a swimming pool. By blowing up the lilo, it gets rid of all the folds and gets rid of the folds in the cornea as well. They have moxibug hourly, unpreserved dexamethasone. They slowly reduce over the next few days. They have 1 month of drops altogether, and the storage changes to FML after a while. So just a reminder of what kind of patient has LASIK. For my place, they'll be over 25 years of age. They can have it if they're younger. Lots of places do. We used to not do laser under 21 years of age, but now the hospital's changed. If they've got a stable prescription for 3 years, they can have it if they're 18 or above. Healthy pentacam, not too myopic. And again, the commercial clinics do like LASIK because it's a quick miracle that gets patients back in again, whereas PRK is slow and painful, so the commercial clinics tend not to like PRK quite so much. When people do get glare and halos, well, that's expected. They will get that for the first few days, and then gradually settle down over the next few weeks. I won't talk about complications, because more, unless you want to talk about complications, but I'm going to talk about PRK for a bit. So PRK, we used to call it LASIK before the pandemic, but with the mask on and LASIK and mumbling eye surgeons that don't enunciate their words very clearly, we've decided to call it PRK because nobody can mistake PRK with LASIK. Again, that's for younger people or people going to the armed forces or police, etc. They tend to prefer that. It's not a requirement nowadays in the UK, but anyone who's likely to have an injury to their eye and get a dislocation of their flap. So the armed forces still do like surface treatments. And if you do contact sports, perhaps like boxing, football, if you're going to get an elbow in your eye, it's worthwhile perhaps having the PRK. The idea of it being painful, I'll talk about earlier on. So the epithelium is removed by the laser with the Schwinn, the trans-PRK, and that means the laser's got to guess what the epithelium thickness is. And they've got to guess about 50 microns, but it can be up to 80 microns. It's different, it's thicker inferiorly and medially. So I tend to prefer the alcohol solution, which is 20 seconds of 20% alcohol in this ring here. and that's the drop of the 20% alcohol dropping in there. And that stays on for 20 seconds, and it loosens up the epithelium, so the epithelium comes away. You don't have to scrape it off at all. You can take it off with a sponge. It comes off like taking a tablecloth off a table, very, very easily, to reveal the bare cornea. And then the same residual stromal bed rules apply for PRK or for LASIK, minimum of whatever you want, 300, or if you're me and you're cautious, 350. On the day, they'll spend a bit less in the hospital than the other patients, maybe an hour and a half. They arrive, once again, they have the post-op chat about the drops, they come into the laser room. I tell patients that, again, there are no needles, no knives, no blades. They lie down on the bed. We do the normal WHO checklist and consent and laser, check them on the machine as well. And they put numbing drops in each eye, proximeticaine, a bit of povidone iodine, again, some tetracaine, and then we put the ring on with gentle pressure with the 20% alcohol, 20 seconds, loosens up the epithelium, removes the epithelium. Again, we do the iris registration. Sometimes I'll do it before removing the epithelium. Sometimes I do it afterwards. It's still a good view, even though the epithelium has come off, but it's slightly clearer before. So I tend to do the iris registration before then. And then just the same for the LASIK, about 18 microns per diopter, loud tapping noise, or depending on how fast it is, how many hertz the laser is. For the longer treatments, the longer seconds, the patients say I can smell burning, but they can't, because we all know that the excimer laser it's not a heat laser. It doesn't work by photocoagulation, it works by photodisruption. It dismantles the molecules. And us human beings are made up of carbon and hydrogen and oxygen. When these atoms are made into a aerosol and the patient smell the carbon atoms enter the nose, the brain thinks carbon, burning, but it's not burning. Love the smell of napalm in the morning, I think is that. Once the excimer laser has completed its treatment of how many seconds it's going to be, mitomycin C, as we mentioned it on, is applied for, I put 45 seconds on. It immobilizes the keratinocytes because it does an alkylating agent that crosses DNA. And scarring is really very, very rare. People say that with the mitomycin C nowadays, you get corneas as clear as gin. Then I put a bandage contact lens on and they go home and I give them numbing drops. We all give the numbing drops to the PRK patients because they have 3.5 days of the epithelium to heal up. And day 1 and day 2 is particularly painful. Day 3 and 4 is not so painful. And when I see people afterwards and say, how was it? They tend to say that the vast majority say, yes, it was what you said. It was uncomfortable. It was painful. Bright lights were uncomfortable. I couldn't really do very much, but I used the numbing drops. Didn't use them all up, but it was bad. It was what it was. It's fine. It's healed up. So a small minority would say, no, I didn't think it was bad at all. In fact, I went out to the pub with my friends. I had a nice time. No, I thought you were overdoing it, telling me how painful it's going to be. And then there's another group at the end of the spectrum, another small group, say, oh my God, that was the worst pain I've ever had. If I knew it was like that, I would never have had it done in my life. It was awful. But for those people, we do give them numbing drops. We also give them sleeping tablets as well, some zopiclone. And I tell them that the proximeticaine is their one and only true friend, and use it sparingly, because if they use it with gay abandon too early and it runs down their cheeks into the carpet, they'll be wringing out the carpet to try and get every little drop of proximeticaine they've wasted. Then it's a slower visual recovery as well, post-PRK. So during 1 to 2 weeks, 50% of people get their driving standard vision back in the first week. The other half get it back in the second week. I say that, but often it's daytime drives, daytime familiar drives that they want to do. They won't want to do nighttime drives because they will still have glare and halos at night. After 3 to 4 weeks, and after 4 weeks, they're able to see everything pretty much easy. They can look around, they can read, they can see the distance. It's all fine and good, but they're a bit disappointed. It's not that great. But then at 6 weeks, it gets much better and better. So it crisps up more and more. By their 6.6 by 6 weeks. And then I tend to see them 3 months after that 6-week appointment. And by then, they're getting their 6.5 vision. Some people, about a third, start to find out that they're fine. They don't have any glare. They don't have any halos. They don't have any dryness. But at 3 months, bang, some of them start to wake up in the morning with recurrent erosion syndrome symptoms. And if that happens, they get in contact with me, and I usually just prescribe some hyaluronide ointment, and it tends to settle within a few days or a few weeks. It doesn't persist. What kind of patient PRK? Well, for me, it's those with the thin corneas, healthy, normal corneas. So with the Bell and Ambrosia, I like the green. They could be a little bit thin. And if a younger age, I'm more likely to recommend PRK. And I'll often explain it to them with this little kind of diagram, which I routinely do again and again and again and again in clinic, showing them how much their residual stromal bed will be if they had LASIK, and how much it would be if they have PRK, just to explain why my rationale is, and they're up to them to decide sometimes. So that's kind of it for LASIK and PRK. Who's suitable for LASIK? Slightly older patients, 20s and more, 30s, 40s, normal pentacam scans. Again, my mantra is like when you're doing cataract surgery. You have the kind of mantra that you repeat and just lay in your brain. So for cataract surgery, it's consent, marked, drops, biometry. Consent, marked, drop, biometry. In LASIK, it's young age, thin corneas, high treatment. Beware of those things. And if they outward bounded people who go charging down mountains on bicycles and fall through bramble hedges and knock themselves on rocks might be better having a PRK so they don't dislodge the flap. Dry eyes doesn't seem to be much of a problem. If you were to Google LASIK ruined my life, and I tell patients to do that, you will find a mixed bag of people. It's not all dry eyes, actually. I've looked at that website to try and make sense of it, and it's just people who are unhappy with their surgeons, either because they can't contact them, they can't make a follow-up appointment, they don't get a kind of answer to their questions, so it not really helpful. But dry eyes doesn't seem to be such a big problem after LASIK, in my experience. I know there are some people who have aberrant neural degeneration and almost like phantom pain after LASIK, but I'm very lucky so far. I don't want to jinx that, but I haven't seen that. And some people don't like the idea that the flap never really heals. So it's possible to lift the flap for redos or laser enhancement 10, 12, even 15 years later. When you're getting over 10 years, it's slightly more likely to get epithelial ingrowth when you lift the flap. Under 10 years, a lot of surgeons would lift the flap to redo any treatment. I don't do SMILE. We did get the Zeiss laser here to do SMILE at Moorfields, and then we sent it back a few years ago because we didn't get great results with it. Other people do get great results with it, and we've now got the VisuMax laser again. So some of us are starting to do SMILE all over again. What if they're too short-sighted? ICL, and I do like the ICLs. If you were to Google ICL ruined my life, you won't find a hate group online for ICLs, because the intraocular column lens are a great lens. It's a very well-studied lens. About 10 years ago, the ICL company, Star, who make the ICL, put a little hole in the middle of the lens, which meant that the incidence of cataract went down from 5% to 1%, and the pressure issues, as long as you don't leave any viscoelastic behind, evaporated and made it a much safer lens to use. And once again, as I mentioned earlier on, even if they're not very short-sighted, but have corneas that are not suitable for excimer laser, then consider the ICL implantations. Nope, we don't have her today doing that. So there are excellent results for myopia and astigmatism. And you can see the little hole. I don't how anybody thought that was a good idea, putting a hole bang in the middle of the optic. I don't know, but it doesn't affect the vision at all. They don't get more glare or halos because of it, and yet they don't get cataract. I've been putting them in for about 8, 9 years now, and I haven't had to remove one yet because of cataract. I'm sure I will have to, because they will get them at some point. I tend to say, people, if you've got cataracts in the family, for your grandparents or your uncles and aunts, and they get their cataracts when they're in their 70s or 80s, if you have the ICL implanted, you may well get cataract perhaps in your 50s or 60s. But often we're talking to people who are in their 20s or early 30s, and usually they're myopic in the extent of minus 10, 12, up to minus 18. So they're more at risk of getting cataract anyway. So that's not a problem to them. The internal antechamber needs to be a depth of 3.0 millimeters, and that excludes most hyperopes. But if you get a hyperope who does have an internal antechamber, that's from the endothelium to the lens, of 2.8 millimeters, you can put an ICL in them, but the hyperopic ICLs do not have the hole in the middle. I imagine it's because the lens is thicker, and therefore they can't put the hole in the middle. So you have to do automated PI with the retractor on those patients. So that's a little bit more involved. You have to make sure they have a normal endothelial cell count, and I follow them up. A lot of eye surgeons won't follow up ICL patients. They'll see them for 1 year, 2 years, and then they say goodbye to them. But because they are at risk of cataract, and I'd like to get the endothelial cells count followed up over the years, and even check the pressures for any glaucoma, I do tend to follow them up forever, even if just once every 2 years. Preoperative tests, we do the pentacam again, just to look at the internal anterior chamber depth, the IOL master for the white to white. There are many different ways of measuring the white to white, the limbus, whether it's going to be an anterior segment OCT or an IOL master or on any other scan. It doesn't seem to make much difference how you measure the white to white. If I measure it on the IOL master, I reduce 0.4 millimeters, but that's a standard thing that everybody does, and that's easily available. And they make sure they have a stable refraction and a normal ophthalmological examination. The online calculation on the STAR website is very simple. You just have to plug in the details and they tell you which lens to order. And it can be up to minus 20 diopters. Small risk of cataract, excellent astigmatic correction. When it comes to marking patients for astigmatism, we all have our different ways of doing that. And I tend to do it when they've come into the anesthetic room and they're lying down. I know when they're lying down, the eyes can rotate a little bit, but if both eyes are open and they're not anesthetized and they're looking directly at me, I find it much easier just to put a little sterile felt tip pen mark at 0 and 180. And then if they are going to have a subtenons and they come into the operation room, they've only just had the mark, so it hasn't had time to wash off. It gives great quality of vision. They do get glare inhalers initially, and these can take months to settle if you do get them. Not everybody gets them, but I haven't had to explant ICLs for visual symptoms. There's a very low loss of endothelial cells, so which is why some surgeons don't offer any follow-up, and they're easy. They're easy to implant. They're more difficult to load into the cartridge than it is to implant into the eye. Very easy. Intraocular surgery does mean going into the operating theatre, so that puts up the costs for the patient, so it makes it much more expensive. Bilateral simultaneous is most common these days, but either topical with sedation or maybe one eye subtenons, one eye topical. And for toric lenses, I prefer subtenons because it means that they're not moving or wincing with the light, and they haven't got the bells, so it makes it more accurate implantation. And so if people are getting for, I'm just thinking of the people you meet in the pubs, not him probably. And if they're getting on for -7, -8, up to -20, then you can tell them ICL is the option for them. So if they're low myopes or even quite high myopes, they can have LASIK depending on how old they are, really. PRK is always an option. A lot of, if you ask the laser nurses who work in our laser suite whether they'd have LASIK or PRK, they all say I'd have PRK. And if the person you meet across the dinner table, the man or the woman you're chatting to is very short-sighted, then you might want to consider ICLs for them. But more and more of my patients in the clinic now are the presbyopes who are coming in their late 40s, early 50s, early 60s, who are low hyperopes, who want to get rid of their glasses, and they are great for refractive lens exchange and having a multifocal lens implanted. The multifocal lenses I've used in the past, over the last kind of 15, 20 years, I did use the M plus lens an awful lot, but then I was one of the generation of surgeons who got stung by these lenses going cloudy. And removing these lenses and putting new lenses in is a nightmare. Almost 50% of the time, or maybe 30, 40% of the time, removing these lenses that have previously undergone YAGs and have the capsule shrink wrapping the lens, trying to dissect them out. Often you find you're putting an anterior chamber lens in. And that's a big disappointment. Even though the patients are older and they kind of get a clear lens back in again, some of them are very unhappy. And obviously doing the surgery runs a risk of cystoid macular edema. So anyway, I tend to not, and these are hydrophilic acrylic. So I'm moving more now towards the Alcon Vivity lens, which is hydrophobic acrylic, therefore less likely to have the opacity problems that the hydrophilic lenses can occasionally have. For the Zeiss, I use the Zeiss trifocals. Any trifocal is all fine and good. The trifocals are good for people who want to have better reading. So if they want to have better reading, and I warn them when I say, but you run the risk of halos at night. If they don't mind that, then they have the Zeiss trifocal or Panoptics or any other trifocals. If they do not want to have nighttime problems, then I go for the Alcon Vivity, warning them that it'll give them good distance vision, reasonable near vision, occasionally needing some +150s over the counter or from Amazon or any other provider for small print or dim light. And at the moment, I'm putting more Vivities in than any other lens. So once again, I don't like doing it, particularly in people in their 40s, because of the long-term cumulative risk of retinal detachment, which is not that high, but it is still there. If they've got a lot to gain, i.e. they're +3s, +4s, and they're in their late 40s, then I think a lot of eye surgeons would probably do clear lens extraction, refractive lens exchange with a multifocal lens. The happiest patients are obviously those with the most to gain. It sounds kind of foolish to say that, but if an emmetrope comes along in their 50 and they want to get rid of their reading glasses, I warn them that they have brilliant unaided distance vision, and anything I do is going to destroy that, and they're not going to be happy. Warn them that people who are emmetropes are not happy, or a lot of them are not happy after having refractive lens exchange. There's got to be more to gain than that. And it's the hyperopes that do have it, because they get rid of glasses for distance, which makes them very, very happy. And look at this, they've even got rid of glasses for quite a lot of reading. So they are the happiest ones of all. We all know that low myopes avoid them because they've got this wonderful, wonderful ability to read without glasses, and whatever we do, we are going to rob them of that. So they're not the good ones either, unless they absolutely know they want to get rid of they want to have good distance vision. And if they're absolutely sure, then occasionally I will do it. High myopes, I warn them that they have a superpower. So the -7s, -8s, -9s, their superpower is that there is nothing they cannot read when they hold it very close to their eyes. And it's worth reminding them that they are going to lose that by having refractive lens exchange, because a lot of them, curious enough, don't realize that. So they have a superpower. On a not so much a refractive point of view, but occasionally when you get people with very poor low vision because of retinopathies or retinitis pigmentosa, if they're very high myopes, even though they are certified as poor vision, they do find that they can read very, very close up. And when we do their cataract surgery and make them emmetropic, they can be superbly unhappy by losing their high myopia, which especially when they're low vision people, is their only way of seeing things by holding it very close up. I'm not going to talk too much about callisto optics, which at Moorfields sometimes the internet is good enough for it to work, and then you can get brilliant alignment of your toric lens with the little markings on the lens, but often the Wi-Fi lets us down, so I end up just doing it with the marks anyway. Luckily, we NHS routinely use toric lenses for people who are more than 1.75 or even 1.5 diopters more of corneal astigmatism. So rarely in their 40s, unless they've got a lot to gain, the high hyperopes. The retinal detachment increase. Acrylic lenses, hydrophilic or hydrophobic, I tend to moving towards the hydrophobic lenses, or there are perfectly good hydrophilic acrylic lenses that are multifocals. And always, monofocal lenses are always going to give the best quality vision, and that's what we routinely use in NHS. But more and more people now, especially with some of the eye harms, the small 0.75 reading ad, or Rayner, Ray 1, MV, that more and more I'm recommending multifocal lenses, even if it's a tiny little reading ad. It just means that people can see more, and the newer lenses have fewer and fewer nighttime vision problems. Traditionally, we'd say that multifocal lenses are for couch potatoes who don't have very demanding visual, not visually demanding, or for just people who want to go out and see the menu and don't drive at night, don't read documents, or don't do anything else. But it's getting more and more for everybody. And the newer designs I've mentioned already. I'm not going to go into the EDOF lenses too much, but a small reading ad, the Rayner Ray 1 is a good one. Hydrophilic, alcohol vivity is the preferred one at the moment.